Thank you, madam. And I'd like to start by thanking the College of Physicians for giving us this opportunity to share some aspects of hematology today. So my topic is a practical approach to starting DOACs. This is the outline of my lecture. So I'll start with a small introduction to DOACs or NOAC. So is it DOAC or NOAC? To find out that, we had to go back to 1954. That's when warfarin was introduced. So for about 50 years, we didn't have any other alternatives for oral anticoagulant drugs till in 2004. The first direct thrombin inhibitor went into clinical trials, but it was rejected because of hepatotoxicity. And in 2009, dabigatran is the first of the oral anticoagulant alternatives to warfarin. So because of that, they were started calling novel oral anticoagulants or new oral anticoagulants, and the acronym NOAC came into being. After that, every 2 years, we got new anticoagulants. So then came rivaroxaban, then apixaban, followed by edoxaban. So after some time, they were not novel or new either. So then they started calling them direct oral anticoagulant drugs. Then the NOAC thing came back, this time calling them non-vitamin K oral anticoagulant drugs. So whatever happens, it's DOAC or NOAC, you will see them used interchangeably. So what are the drugs we have? So we have inhibitors of thrombin, which is dabigatran, which is required for the final conversion of fibrinogen to fibrin. Then we have anti-10A or activated 10 inhibitors, rivaroxaban, apixaban, edoxaban, and batrixaban. So the XA here stands for 10A from your clotting pathway. So you can remember that. Now, what is great about these new oral anticoagulants is that you don't have to routinely monitor their response. They have less food and drug interactions as compared to warfarin. Now, we have two DOACs available in Sri Lanka, apixaban and rivaroxaban. But the issue is there is no head-to-head comparison between the four main oral anticoagulant drugs. Therefore, when it comes to starting a patient on DOACs, things can be a little bit difficult, and you might want to know a bit of knowledge to make sure that you give the right drug to the right patient. So these are the indications that have been approved by the EMA as well as the FDA. So just to go through them one by one. So the first one was prevention of VTE post-orthopedic surgery. Then for treatment of acute VTE, both DVT and PE during the initial stage of 3 to 6 months. Extended treatment, that is beyond 6 months, even if you're taking lifetime at a lower dose. Then the prevention of stroke in AF. Treatment of acute coronary syndromes in the acute phase, as well as chronic coronary artery disease and peripheral artery disease. So there's license for DOACs for all these indications. Now, if we look at the data first, what we have, I think it's worthwhile spending some time. So these are the main pivotal trials for atrial fibrillation: RELY, ROCKET, Aristotle, and ENGAGE. One thing I wanted to just draw your attention to is this thing called time in therapeutic range. So that is a percentage of the amount of time patients were on INR. This usually we'd expect a figure of more than 70 as pretty good. But what you see here is in these comparators, so all these DOACs were compared to patients on warfarin. They were quite close to that 70 mark. So what I want to say is that these DOACs were compared to a group of patients who were fairly doing well in their INR values. So dabigatran was checked at 2 doses, 110 and 150. It was equally effective at 110, superior at 150 in reducing recurrent stroke. Rivaroxaban at 20 milligrams were equally effective. It was a non-inferiority trial. Same with apixaban and same with edoxaban. There were 2 doses, 30 and 60. Both were equally effective. When it comes to bleeding, in dabigatran, the lower dose was in terms of superior to prevent bleeding, but the higher dose of 150 had higher bleeding risk, especially GI bleeds. Rivaroxaban also had lower incidence of hemorrhagic stroke or ICH, etc., those sort of bleeds, but increased risk of GI bleeds. Apixaban did not have any GI bleeds or intracranial bleeding risk. Edoxaban, the lower dose did not have an increased bleeding risk, but the 60 milligram dose did. Another interesting point when it comes to the AF trials is the valvular heart disease group, atrial fibrillation secondary to valvular heart disease, was quite poorly represented, about 20%, 14 and 26. Even in that, there was no moderate to severe mitral stenosis patients. Then we go on to the randomized control trials that looked at DOACs in VTE. So you have Remedy Resonate looking at 2 doses of dabigatran, then Einstein and Amplify. The third or the last one is called Hakusi. That is the one that compared edoxaban. All of these trials were non-inferiority trials. So they showed that the DOACs were equally effective in preventing recurrence of VTE. When it comes to bleeding, dabigatran and rivaroxaban had similar bleeding episodes as compared to warfarin, whereas apixaban and edoxaban had a better bleeding profile. So in summary, if you look at these trials, but the driving point is that in terms of anticoagulation, DOACs are probably equally effective. They're not superior, that we know. In terms of bleeding risk also, there's a marginal benefit. It is not really fantastic. So keeping that in mind, the only time where the anticoagulation benefit was in patients with cancer. As you can see, the recurrence rate was reduced significantly compared to this is low molecular weight heparin. So how did that happen? So first they compared vitamin K to low molecular weight heparin, and low molecular weight heparin was shown to be superior in terms of preventing recurrence of cancer associated DVT. Then they compared low molecular weight heparin to the DOACs, and again it was equally effective, and there were some studies that showed that it was also beneficial. It's pretty obvious why those findings came, because if you think of cancer patients who are on warfarin, they have very poor appetite, they have vomiting, they are always on antifungals, antibiotics, they are frequently on IV antibiotics. So there's no surprise that cancer patients don't do well on warfarin. So the only instance where an anticoagulant effect was beneficial in DOACs was only in this patient group of cancer. Right, so having that knowledge of randomized controlled trials, I'll go to the topic of choosing a DOAC. So if you have a patient you think will benefit from a DOAC, I like to go through this process. So first find out, is the DOAC going to be effective in this patient? Next, what is the cost and access to reversal agents? Assess the bleeding risk. What is the creatinine clearance? Any drug interactions that might hamper your decision giving a DOAC or one DOAC over the other. And finally, personalize the anticoagulation depending on the patient's lifestyle and other factors. So let's go one by one. What are the contraindications of DOAC? So the first thing I'll look for is it contraindicated? So if you take atrial fibrillation, somebody has atrial fibrillation secondary to mechanical heart valves, DOAC is a no-no. Mechanical heart valves in general, you should not give DOACs because there's only one trial, that is dabigatran. They tried at 150 milligrams, which had huge bleeding and thrombotic complications. So mechanical heart valves out. Mechanical heart valves with atrial fibrillation also out. Moderate to severe MS, like I said before, they were poorly represented in all the main clinical trials. The reason for that is if you have moderate to severe MS, there'll be significant pressure increases in the left atrium, and there'll be almost permanent wall changes that will give you a predisposition for intracardiac thrombosis. Therefore, if you have moderate to severe MS, even if you repair it with either a biological valve or a repair, you will end up with that similar risk. So if you get a patient with atrial fibrillation, always go to the echo findings and see if these underlying issues are there. Then we go on to VTE, antiphospholipid syndrome. All the DOACs did very poorly when they were given to APLS patients, especially the ones who had arterial stroke and especially the ones who were triple positive. That is anticardiolipin, beta-2 glycoprotein, and lupus anticoagulant. So the final nail in the coffin was apixaban trial also, which is kind of coming up as a more fashionable one, also did poorly with antiphospholipid syndrome. Thrombosis at unusual sites. So what I mean by this is superficial vein thrombosis, portal vein thrombosis, and cerebral venous sinus thrombosis. Now these patients were also not poorly represented in the main trials, but we have emerging evidence that the DOACs are useful in this patient setup. However, a word of caution is when you have especially extensive thrombosis, portal vein, splanchnic vein, all those extensive thrombosis at an unusual site, I would be hesitant to start a DOAC because we don't have enough experience with those kind of thrombosis. Then everybody as a whole, pregnancy and breastfeeding, classical contraindication, but there are very good pharmacokinetic studies to show that it is safe to be given in breastfeeding, and there are 2 clinical trials. So you'd expect this also in the next 1 or 2 years to be registered. Now that will be a huge thing because postpartum VTE is relatively common, and giving the option, an oral option, would be quite useful. Extremes of body weight. So again, patients who were either more than 120 kilograms or BMI of more than 40 or less than 40 body weight were excluded from the trials. And unless you have monitoring of anti-10A levels, it's not a very good idea to use DOACs in this patient group. So the first thing is just see if any of these are there in the patient that you have been referred to start a DOAC. Now, this usually probably comes right at the end in any discussion about choosing a DOAC, but in our context, right now it comes at the top because it is not available in the government sector as far as I know, but probably will be soon. So the cost is about 500 to 600 rupees for the original brands of apixaban and rivaroxaban. When I checked last week, they also said they have a generic for 200 rupees of rivaroxaban once daily. Now that is going to be the trend because all the DOACs will lose their patent in the next 2 or 3 years, and we'll be getting good quality generics coming out. So I think it's safe to assume that maybe in another 2 or maybe 1 or 2 years that we will be able to give good DOACs at a cost of about 200 rupees per day. Now, the other problem is when it comes to reversal. Now, always those who are for warfarin, which is a dwindling number, will say that warfarin can be easily reversed with vitamin K and FFP. And you didn't have proper reversal agents for the DOACs. Now, there are 2 reversal agents. One is idarucizumab, which is a monoclonal antibody against dabigatran, and adexanet alpha, which is another 10A molecule similar in structure to the DOAC. So what it does is it will go and take over all the excretory sites of the 10A inhibitors so that your natural 10A levels will increase. Now, availability is a problem. We don't have either of these reversal agents here. And even in developed countries, for a publicly funded health system, adexanet alpha is exorbitant, hugely expensive. So unlikely it's going to get approval. But we have PCC, that is prothrombin complex concentrate, which is a plasma-derived product of factors 2, 7, 9, and 10. Now that, my experience is, you can manage DOAC bleeding quite comfortably if you have this PCC available, but it is not available anywhere. In the teaching hospitals and all the big hospitals it's available. So I think it's a good idea if you have a patient with increased risk of bleeding, just to see how soon in an emergency will you be able to get to a place where there is a reversal agent. Just on the subject of reversing NOACs, for completeness sake, I'll just go through this. So if a patient comes to you with bleeding and on a NOAC or a DOAC or bleeding, the first thing to do is to ask what time you took the drug. Because the good thing about these is they have very short half-lives. So you really need to support the patient for those 6 hours or 10 hours where the drug is going to be effective. Take a blood sample to see the hemoglobin and the creatinine clearance and calculate it and see, depending on the patient's creatinine clearance and the last time the patient took the drug, how long is it going to be there. If it's a mild bleed, you just have to monitor the patient and take off the drug. If it's not minor, anything significant, obviously you'll try your supportive measures by fluid resuscitation, blood replacement, platelet replacement if required, involve the surgeons and the radiology team to see if there's any local compression or something you can do. And also tranexamic acid, anything other than GI bleeds, and maintaining tissue perfusion till that duration goes. For dabigatran, because it has 80% renal clearance, there's option of dialysing. And the other ones, the specific reversal agents, are either the ones I talked about. So if those are not available, you have to go for PCC. So that's just for completeness sake. But coming back to our original structure, so the second thing you have to do is to see if in an emergency, are you able to manage this patient like this? Number 3 is assess the bleeding risk. Now, for any patient who has been starting on anticoagulation, a good practice is to do a structured assessment of the bleeding risk. We frequently use this Hasbled score, which gives 1 point for each of these, which is hypertension, abnormal renal and liver, stroke, bleeding. L is for labor INR because this was originally designed for warfarin patients. Elderly, drugs and alcohol. So the more factors you have, the more risk of bleeding. Now, this is not meant to be used to decide to give or not. You have already decided that you are going to give this patient DOAC. The use of this is to intervene for these risk factors, right? So if the patient had 3 risk factors, say was taking alcohol, poorly controlled hypertension, maybe poorly controlled liver or renal disease, you can intervene and bring those 3 risk factors to 0 and push the number of the probability of the patient getting a bleed significantly, right? So because if you have 9 points, it's about the chance of you getting a bleed is 10 per 100 patient years, whereas roughly it's about 1 per patient 100 years if you have 1 risk factor. So do a structured bleeding risk assessment and intervene if you can. Number 4 is calculate the renal clearance. Now, you can't go by estimated GFR. You have to calculate using the Cockcroft-Gault equation because, again, all the clinical trials use this to modify their doses. So, no shortcuts, calculate and see. If the creatinine clearance is more than 90, you cannot, it is not recommended to give edoxaban because they say that the elimination will be too much and you won't have enough drugs. Especially the crowd in US are quite convinced with this, but not the others. Now, why I say that is, out of the DOACs, edoxaban will be the cheapest when we have all of them. So that will be your first go-to DOAC. But if this is more than 90, which is not infrequent, you meet quite a few people who have more than 90 creatinine clearance, you would want to exclude your edoxaban. If you have reduced renal function, then you'll have to dose reduce. If you think about dabigatran, you can go up to 50. After 50, you have to dose reduce. After 30, you can't give. The other 3, you can use with caution up to, you can use with the normal dose up to 30 EGFR. And between 30 to 15, it is lower dose with caution. And anything below that, you can't use. Right. Next one is drug interactions. So DOACs all 4 of them use the P-glycoprotein pathway for elimination. P-glycoprotein is a surface protein where which puts out drugs. So it's absorbed in the GI tract. The P-glycoprotein will be putting it back to the lumen. So all 4 of them use P-glycoprotein. Rivaroxaban and apixaban also has a liver metabolism using cytochrome 3A4. So just go through all the drugs the patient is on, and you have to make sure there are no drug interactions, because these can be significant. Up to 2 times the drug levels can fluctuate if they are concurrently on one of these drugs. So there is a nice comprehensive list in the European Heart Rhythm Association guidelines. I will come to that at the end, where if your patient is on another drugs, you can nicely cross-check with that list whether you can give a DOAC or not. Finally, so you have gone through this process, you come to the business end of things, you are going to prescribe the DOAC. You will also have a discussion with the patient what they would prefer. So the dosing is like this. So if you take dabigatran, it is take twice daily, apixaban twice daily, edoxaban and rivaroxaban are taken once daily. So that might influence the patient's choice of what they are going to use. Rivaroxaban has to be taken with food, otherwise the bioavailability goes down by 40%. So you have to mention that. That will also influence what type of anticoagulation they'll use. For DVT, 2 anticoagulants, that is dabigatran and edoxaban, has to be covered with 5 days of heparin, right? So 5 days of either unfractionated heparin or low molecular heparin, followed by the standard dose of 150 or 60 in the case of edoxaban. For apixaban and rivaroxaban, there is no IV phase. You give a loading dose. In the case of apixaban, it will be 10 milligrams twice daily for a week and go back to 5 milligrams daily. In the case of rivaroxaban, you give 15 twice daily for 3 weeks, then you go on the maintenance. So again, that will also be something that you will consider when you're choosing your DOAC, if the patient doesn't want to get that IV and so on, and even the cost. Right. Then this thing about minor bleeds. Quite a few patients will have what is called minor or nuisance bleeding, especially females who are having menstruation will have significant menorrhagia with their if they are on DOACs. Now, those sort of patients who have these bleeds, it will be useful to use a twice daily one, because the drug levels are lesser like this, as opposed to getting something like rivaroxaban, where you'll have very high peak blood levels and coming back to the baseline. So those type of patients, you would consider going for a twice daily dosing, or if these problems arise, you can switch later. All tablets can be crushed except dabigatran. So for patients who are finding it difficult to swallow or who are on NG tubes, that's something to consider. Risk of overdose, probably rivaroxaban is the best if the patient is an elderly patient who's not good with their medications, and if there's any risk of suicide, because rivaroxaban has a ceiling effect. After so many tablets, you take 50, after 50 you take 100, the effect of rivaroxaban is going to be, well, it's going to be significant, but it has a ceiling effect. So there are these little idiosyncratic features for the drugs. These are the main ones, but you probably want to have a good discussion with the patient, giving all this information when you're finally going to decide. Right, so that's what the process I follow if you want to start a patient on DOAC. So first thing is, are there any contraindications? If there are no contraindications, can the patient afford it? Can the patient get to a decent hospital if there is a bleed? Number 3, do a structured bleeding assessment. If there are risk factors, you can intervene. Calculate the creatinine clearance, dose adjust. Sometimes edoxaban might not be the ideal choice in that case. Drug interactions, go through a detailed drug history. Any drug the patient is on, cross-check with the recommended recommendations to see will there be a significant interaction. It's important because we are not monitoring, as opposed to warfarin. Warfarin you are monitoring with the INR, but in these patients we are not monitoring levels. So it's important that you get these things very clear cut. Otherwise, you will have bad outcomes. Then finally, discuss with the patient how often the patient wants to take the drug. What about giving IV first? What about taking it food? What about other bleeding? So on and so forth. Right. So then switching to from the vitamin switching to a DOAC, very simple. So if you're on a warfarin, you check INR after about 2 days. When it's less than 2, you can start the DOAC immediately. If you're on unfractionated heparin, wait till the infusion is over. As soon as the infusion stops, because the half-life is about 1 hour, start the DOAC. Low molecular heparin, wait for the next dose. So if you're on a BD dose, 12 hours early. If you are on a single dose, 24 hours later, take the DOAC at the next scheduled dose. Then finally, arrange a follow-up for the DOAC patients. As all oral anticoagulants, educate them about the risks of bleeding, about taking it properly, etc. Document in their clinic book, or ideally give a card which says you're on anticoagulants and this particular type of anticoagulants. So anyone who starts new drugs will know what to do. Standard recommended follow-up is after you start, you see the patient in 1 month, and after that, every 3 months should be adequate. At each visit, review the indications. Indications change, evidence change as we go on. So always review the indications. Check if there are any bleeding events, if there are any thrombotic events. Check the renal function, especially in elderly or patients who have labile renal functions, such as diabetic patients and so on. So might have to dose adjust. One thing I forgot to mention is about liver disease. So when it comes to liver disease, severe liver disease defined as Child-Pugh stage C, it's a contraindication for DOACs. Then finally, review any new drugs that the patient was started on. And as always, check for adherence and any new side effects. So this is where I would suggest there are about 4 articles from the European Heart Rhythm Association about practical use of DOACs. It's got that extensive list of drugs, which is quite useful to refer to. And then if you want to be updated about the evidence, I would suggest this article, which came about a year ago. After that, maybe there were about 2 RCTs about cancer thrombosis, but this is really a good update. So I think I'll finish there. At the end, I can take any questions. Thank you.